The National Cancer Institute estimates around 60,000 Americans are or will be diagnosed with pancreatic cancer this year. I'm Hartford Healthcare's Tina Verona. Thanks so much for watching Connect to Healthier Live with the Hartford Current. I'm so happy to be joined right here in studio by Dr. Bret Schipper. He's Chief of Surgical Oncology at Hartford Hospital. Thanks for coming in.
Thank you for having me today.
It really is nice to see you here in the studio.
It's great to be back in the studio.
Absolutely. Well, it is Pancreatic Cancer Awareness Month, the month of November, really shining a light on pancreatic cancer, but really it's something that we should be doing, talking about all year, because most pancreatic cancers are discovered too late. Why is it so difficult to detect this type of cancer?
Yeah, unfortunately, where the pancreas is located, it's very deep in sort of the central part of your upper abdomen. And we don't have a lot of good screening tests to evaluate that area. And unlike, a woman's breast that they can feel and evaluate for masses or potentially, bloody stools, which you might get with a colon cancer, we don't have a lot of good signs to look for pancreatic cancer until, unfortunately, it's too late. So really, we don't have great screening for pancreatic cancer, and that's unfortunately why we usually find it more advanced.
Even though there is no screening, Dr. Schipper, we were talking earlier about genetic testing, and that is sort of the key into finding or detecting people that are at high risk and that you could sort of monitor them and hopefully catch it early. Talk a little bit about the genetic testing that you do.
Sure. When we talk about treatment for pancreatic cancer, we talk about the medical treatment, chemotherapy, or the surgical treatment, or even radiation treatment, and those modalities really haven't changed much through the years. It's essentially, slightly different drugs, but the same basic surgical procedures, just done in different minimally invasive ways now. So really where we're looking now is to try and move that bar. Again, the survival is still only about 10%. And when you look at other cancers, that's so, so much less than where we've gotten with other cancers such as breast and colon. So where we're looking now is trying to identify patients who are at higher risk for developing pancreatic cancer, trying to find those patients and then figure out how we're going to screen them earlier and be able to catch these cancers earlier while they're still early stage, resectable, and will have a better outcome. And we're using genetics to try and identify those people who are at higher risk. Things like BRCA, which are, you may have heard about for breast cancer, that's one that places people at a slightly higher risk for developing pancreatic cancer. So here at Hartford Healthcare, we're developing a high-risk pancreatic cancer clinic where we're getting these referrals from different places where patients are identified with these genetic mutations. We're bringing them into our clinic, screening them early, and prospectively, meaning going out to try and identify these cancers earlier.
Yeah, I was going to say, so if someone comes to the high-risk clinic, say they're BRCA1 positive, what happens? You screen them initially, but then is there a follow-through?
Sure.
What happens?
That's a great question, and that's actually what we're trying to study right now. There are all sorts of studies going on and consortiums out there trying to answer that question as to how we should study those patients moving forward. Currently, right now, what we're doing is starting with baseline imaging. If they haven't had any imaging of their abdomen, we'll get an MRI, which is one of the most sensitive imaging tests we have to look at the pancreas. We also take a full family history. So if they have a family history of pancreatic cancer, then sometimes we'll go on and go even further and do another test called an endoscopic ultrasound, where we'll put a camera down their mouth that has a ultrasound probe on it and allows us to look very finely at the pancreas and identify even more if we see anything concerning, and then potentially do a biopsy. So it's really individualized to the person and their risk. There's a difference between someone who just may have the BRCA gene versus someone who has the BRCA gene and may have 3 or 4 family members that have all developed pancreatic cancer.
Right.
So there's a lot of research going on right now into that high-risk space, and hopefully that's going to be one of the areas where we're going to be able to move that bar.
And keep moving it and follow those patients through. That's so
Correct.
important. We talk about that and a lot of research going on in terms of early detection and novel modalities to treat pancreatic cancer.
Yeah, so in a lot of cancer care throughout the spectrum, whether it's pancreatic cancer or other cancers, is really becoming individualized to the patient. And we are looking for specific genetic mutations in the tumor themselves that may make them amenable to receive certain targeted drugs that may be specific to their particular tumor. So a lot of research going on that as well, because we know all these cancers are not the same.
Right.
Two people's pancreatic cancers may be very different in their aggressiveness or their markers that they may have to offer different novel therapies.
And Dr. Schipper, I think that's important to stress is that there are no two cancers alike. Every patient is different, and that's why the multidisciplinary approach at Hartford Hospital that every patient goes through is completely tailored and individualized towards that patient. Talk a little bit about the tumor board and that multidisciplinary approach, really zeroing in on that specific patient.
Sure. When we talk about cancer care, we have a toolbox, I would say, of different options, whether it's radiation, whether it's chemotherapy, whether it's surgery, or other interventional procedures. And the real question sometimes is what order we use the armaments in our toolbox. Some patients we know may do better with chemotherapy first, followed by surgery. Some patients may do better with surgery before chemotherapy, or do we add in radiation? And all those questions are very specific to each individual patient and how they're presenting. What stage are they presenting at? What does the imaging look like? Are there lymph nodes involved? All these different factors. And what we do here is we have a multidisciplinary hepatobiliary tumor board where we present all these new pancreatic cancer cases. And at that tumor board, we have physicians from surgery, from medical oncology, radiation oncology, genetics, GI, pathology, radiology, and we go through the whole spectrum of the case. We review the imaging. We look at all the pathology slides to pick up the different nuances. We have the genetics folks there. We have the clinical trials folks to tell us if we have a trial open that this patient may fit. And we all come together with a consensus as to what we feel is best for each individual patient's cancer and how they should move forward. And then that group makes a recommendation. That recommendation is brought back to the patient, and they're actively involved in making the decision on how we go forward.
Yeah, it's so important to have that individualized care. In case you are just joining us, we are talking live with Dr. Bret Schipper. He is the Chief of Surgical Oncology here at Hartford Hospital. Lots of questions coming in on Facebook. We want to make sure we get to all of them, Dr. Schipper. Michael wrote in to ask, can pancreatic cancer be prevented? Michael, thank you for writing in your question.
Michael, that's a great question. And unfortunately, there's no easy answer to that. I think, we see a lot of patients who have no significant risk factors, have no family history, and still unfortunately develop pancreatic cancer. So unfortunately, you can do everything right in your life. You could not smoke, you can eat healthy, you can have an active, lifestyle, and unfortunately, you can still get pancreatic cancer. So there are, certain things you can do to help decrease your risk, things like quitting smoking, things like that. But unfortunately, we really have no good way to prevent pancreatic cancer.
What are, and sometimes, oftentimes, symptoms develop when the cancer is at an aggressive stage or a late stage. What are some of the symptoms, though, that do occur to look out for? And I know they could be a number of things, that could be anything,
Sure.
But still, just for our viewers.
That's one of the hardest things with pancreatic cancer in making the diagnosis, and why, unfortunately, a lot of patients are diagnosed later down the line when the tumors have already grown. The pancreas has a couple of parts, and it kind of goes across your body. There's a head, a neck, a body, and a tail. And in the head of the pancreas, you have a lot of critical structures. You have the bile duct coming in, which is the pipe that carries bile from the liver to the intestine. You have some other critical structures in there. But out at the tail of the pancreas, there's really not much out there. So if you have a tumor that develops in the head of the pancreas, you can start to develop symptoms such as jaundice, because that tumor can grow to a point where it starts to stricture down or block that bile duct. And then one of the classic symptoms is painless jaundice, meaning all of a sudden you just wake up one day and you notice your eyes are yellow, or your skin is yellow, or your urine is very dark, or your stools are becoming light in color. These are all signs of jaundice, which is a sign that that bile isn't able to drain back down into the intestine, is being blocked by something. If you have a symptom like that, that's an immediate urgency to seek medical care. It may not be pancreatic cancer, but it certainly is something critical that needs to be evaluated. However, if you have a tumor in the tail of the pancreas, it can grow to a substantial size before you develop any symptoms, because there's nothing out there for it to really push against. So a lot of times you'll have vague symptoms, abdominal pain, bloating, nausea, but these are all vague symptoms that people just attribute to, lots of other more common things, GI bugs, a dietary issue. So people tend to just put it off and say, this is nothing, this is nothing. And a lot of times it is nothing.
Yeah.
But unfortunately, sometimes it is something. So it can be very hard to diagnose early.
I think the important lesson is to always listen to your body. And if something is not right, you should most likely get
Absolutely.
that checked
If
out,
any
for
symptom
sure.
doesn't resolve within a few days,
Yeah.
I think it's important to seek medical advice.
Absolutely. Pancreatic surgery can be complicated for instance, the Whipple procedure. It's something that you need to be highly skilled at. That's something that you performed, but it's a challenge that you embrace. Tell us about that.
Sure. Personally, as a surgical oncologist, one of the things I like about the field so much is the challenge of everybody's tumor resection. Again, as we talked about before, not everybody's tumor is the same. And pancreatic cancer is specifically known as a bad actor because it can grow into some of the surrounding structures. It can involve some of the major blood vessels that live right there that feed the blood supply to your liver, as well as drain the blood from your intestine. There's some critical arteries that live right there. So sometimes during the operation, we have to figure out how are we going to get this tumor off these blood vessels, and how are we going to do that in a way not to risk the blood supply to the liver or the drainage of the intestine. And sometimes it is a multidisciplinary approach. Sometimes I'll have to cut out a piece of those blood vessels in order to get the tumor out and bring in one of my vascular surgeon colleagues to help reconstruct that blood vessel. So every tumor has its own specific challenges depending on how it's growing, how inflamed the areas are. Every case is sort of a unique challenge and never quite the same every time. So I enjoy that challenge of, never quite doing it the same way, and having different challenges with each patient.
Well, you hear about the Whipple procedure, and it is such an advanced, complicated procedure, but when you hear about what's entailed in that, it is remarkable what you and the other surgeons do. Explain a little bit about the Whipple procedure to our viewers out there watching.
Sure. So for pancreatic cancer, there's really two main surgeries we do, depending on where in the pancreas the tumor is. If there's a neck of the pancreas and anything to one side of the neck, we tend to do what's called a distal pancreatectomy, which is a little bit more of a straightforward operation where we basically cut off the tail of the pancreas. The benefit of that is that we don't have to reroute all the plumbing. It's just one cut on the pancreas, and we usually take the spleen with it as well because that's where the lymph nodes are that drain some of the pancreas. So it's usually a distal pancreatectomy and splenectomy. Again, a lower risk operation because we're just taking those things out. We're not having to reconstruct anything. Unfortunately, if your tumor is to the other side of the neck, in the head of the pancreas or in the neck itself, we have to do the Whipple procedure. And that is a very large operation where we basically have to reroute all the plumbing of your GI tract. It involves removing the head of the pancreas, the duodenum, which is the first portion of intestine after the stomach, a portion of the stomach, as well as cutting that bile duct and having to reconstruct that. So we're making basically three new connections. We're having to, once we remove that, we're having to plumb in the pancreas, replumb in the bile duct, and replumb in the stomach so that the stomach can drain correctly and the bile and the pancreatic juice can get to the food to help digest it.
Absolutely remarkable. I want to make sure we get to Linda's question. She asks, is there a test available that can detect pancreatic cancer? I know we touched a little bit upon that with genetic testing, but I do want to make sure we ask Linda's question.
Yeah, Linda, that's a great question, and that's something a lot of people are working on as well. Right now, we don't have a specific test that can tell you if you have pancreatic cancer or not. There are some tests in the works that can allude to if you have sometimes circulating tumor cells that we're looking at to see if we can use that as a way to help detect pancreatic cancer and other cancers. But at the current state, we do not have any specific single test that can detect pancreatic cancer. Now, what we do have is things like CAT scans and MRIs, which is usually how we detect pancreatic cancer at this point. Again, if a patient comes in with jaundice or abdominal pain that's not letting up, usually one of the first steps is to get a CAT scan or an MRI, and that's usually our gold standard test to make the diagnosis of pancreatic cancer. We then go on to usually do what's called an endoscopic ultrasound, which I mentioned before, which is a more sensitive test that can go down. And the benefit of that test is we can actually biopsy the tumor to confirm it is in fact a pancreatic cancer.
Carrie wrote in to ask, how is pancreatic ultrasound conducted? Thanks, Carrie, for the question.
Yeah, thanks, Carrie. So what I'm assuming you're referring to is the endoscopic ultrasound, because that's typically what we'll do for the pancreas. And again, it's a scope, kind of like a colonoscopy, but this is an upper endoscopy, so going down your mouth. It's a very long scope, and it goes down, and at the end of the scope, there's a little ultrasound probe built into the scope. And the way the anatomy is the stomach sits right on top of the pancreas. So with that ultrasound, they can put that at the edge of the stomach and see directly through into the pancreas, and sometimes get a much more sensitive look at the tumor, at the pancreas. And we use that frequently to help determine if the tumor is involving the blood vessels. They can see that interface between the tumor and the blood vessels. So usually we use a combination of MRI or CAT scan and EUS. It also gives us the ability, as I mentioned, to biopsy the mass, and it also gives us a good look at the lymph nodes around the tumor. And if there is concerning evidence that one of those lymph nodes may look abnormal, they can also sometimes biopsy the lymph node with that endoscopic ultrasound. So it's a great tool that we frequently use for pancreatic cancer.
Another question from Amy. She wrote in to ask, why is it that pancreatic cancer isn't usually detected until later stages?
Yeah, as I touched on before, unfortunately, it doesn't have a lot of good warning signs that there's something growing in your pancreas. Again, the tumors in the tail of the pancreas tend to be detected later because there's really nothing there for them to push on, and they have to grow even bigger before they'll be detected. Again, in the head of the pancreas, you have that bile duct, which is usually one of our early signs that something is wrong. But that's really the key is we don't have a good screening test. It's not like, mammograms, which a woman will get every year and help detect breast cancer very early, or a colonoscopy, which you may get every 5 or 10 years, depending on your history to try and detect it. We don't have that annual screening test to use to really evaluate for pancreatic cancer. So again, as mentioned previously, what we're really looking at now is who are those patients who are at higher risk for developing pancreatic cancer, and how do we screen them earlier so that we can catch it earlier.
Dr. Schipper, do you ever think somewhere down the line, and maybe someone somewhere is working on it, but that there will be a advanced screening for pancreatic cancer, a yearly screening be it, or like we do for colonoscopy and breast cancer?
Yeah, I hope so. I mean, I would love to be out of business in operating on pancreatic cancer, but unfortunately at the current time, we really don't have anything. Again, some of the things they're working on is sometimes the tumors can shed cells into your bloodstream. And there are tests that are being, a blood test where they can look at the blood and see if they find any of these cancer cells. And again, not just for pancreatic cancer, they can pick up all sorts of other cancers in there. So there's work going on that. We're looking for those tumor markers. We have a tumor marker for pancreatic cancer, something called CA19-9. That is frequently elevated in pancreatic cancer, but it's not always elevated in pancreatic cancer. So it's not perfect because we have patients with pancreatic cancer that have a normal CA19-9. So we don't have that real holy grail yet, definitive
marker,
test at this point.
An anonymous viewer wrote in, this is an interesting question. I was told that there is a direct correlation between breast cancer, ovarian cancer, and pancreatic cancer. Can you explain what exactly this means?
Sure. I think that what you're focusing on there is the genetic component like we talked about. So things like BRCA, we know that has a higher incidence of breast, ovarian, and pancreatic cancer. So we do see families who come to our high-risk clinic with the BRCA gene, and they may personally have had breast cancer, or ovarian cancer, or have a family history of these things. And that's where the correlation that you speak of those cancers kind of coming together is really around that genetic component. And if you have that genetic mutation, you're at higher risk for all of those types of cancers. Now, there are a lot of people who have breast cancer or ovarian cancer and may not have the BRCA mutation. So it's not 100% just because you have breast cancer, you're higher risk for pancreatic cancer. You have to have that specific mutation to place you in that higher risk bucket.
Well said, well answered. Charles asks, are there any clinical trials that might be available to someone diagnosed with pancreatic cancer? Thanks, Charles.
Yeah, absolutely, Charles. I think that is really the way we try and advance the science is through clinical trials, where we look at the novel therapies and the new things coming down the pipe and how we integrate that into our current standard of care. So absolutely. There are trials for patients who may be resectable. There are trials for patients who may not be resectable. There are trials for patients with metastatic. And with our connection with Memorial Sloan Kettering as a member of the Memorial Sloan Kettering Cancer Alliance here at Hartford Healthcare, we also have connections with potential trials at Memorial Sloan Kettering. So absolutely, it's always important to ask your oncologist about the opportunity to take part in clinical trials.
Lori asks, is pancreatic cancer genetically passed down?
Lori, absolutely. I think, again, it gets back to that genetic component. And I think currently the standard of care is if you are diagnosed with pancreatic cancer, you do meet the criteria for genetic testing. So anybody with pancreatic cancer should get genetic testing to see if they have any of these genetic abnormalities. Because if you do, then you absolutely need to inform the rest of your children or your family, because they may then carry that gene and should be checked to make sure they're not carriers, and then undergo other screening for potential risk of cancer.
Dr. Schipper, we see in other types of cancer, for instance, such as breast cancer, the numbers are increasing of women developing breast cancer without a family history. What are you seeing with people being diagnosed with pancreatic cancer? Are you seeing that, or are you seeing that genetic correlation there?
Yeah, the thing about pancreatic cancer is it's all comers. I mean, just this month alone, I'm treating a 30-year-old and an 83-year-old. Both, need Whipple operations. So, at all spectrums of the age gamut, and equally in men and women, unfortunately, nobody is immune, unfortunately.
Yeah. We have another question from an anonymous viewer who wrote in, can pancreatitis be a precursor for pancreatic cancer? Also, what about pancreatic cysts? Can these turn into pancreatic cancer? Two really great questions there.
Yeah, so, when we talk about trying to catch pancreatic cancer early, pancreatic cyst is another hot topic. There's a specific kind of pancreatic cyst called an IPMN, which we know can be a premalignant lesion. And there are certain criteria for these cysts that we look at, and if you meet some of these criteria, we do recommend removing these cysts to prevent a cancer. And we remove a lot of these, and it's very gratifying when the way cancer works is it goes on a spectrum. So you start with what's called low-grade dysplasia, meaning things are starting to change, moderate grade dysplasia, high-grade dysplasia, and then in cancer. And what we want to do is remove these cysts before they get to that cancer. And it's always very rewarding when we remove these cysts, and it may have high-grade dysplasia. And we know, if we would have waited just a little bit longer, this could have gotten to cancer. So we really try and look at those pancreatic cysts. And we have a great multidisciplinary approach, again, with pancreatic cysts, because to get the information on pancreatic cysts usually requires an endoscopic ultrasound, where, again, they can aspirate the fluid from the cyst and give us critical information, such as cytology, looking at the cells, is there dysplasia, and also, again, the genetic component. We know there are certain genetic markers within those cysts that we can find, and if you have those, we know they place you at higher risk for turning into a cancer. There's also size of the cyst, greater than 3 centimeters. If it's involving the pancreatic duct, the main duct, and there's dilatation of the duct, all these different things are signs that we should take those out to try and prevent them from turning into a cancer.
And how do they develop?
Unfortunately, again, it's one of those things that nobody does anything wrong. It's not a lifestyle thing. It's not you smoked or you did anything. It's just one of those things that unfortunately just evolves.
And explain for that anonymous viewer who asked the question, and for all viewers, how do you remove those cysts?
So the cysts are removed in very much the same way as the pancreatic cancer. If they're in from the neck, or the tail side, then we do the same thing, usually a distal pancreatectomy. If we don't always take the spleen in that case, if it's not a cancer, but unfortunately, if your pancreatic cyst is in the head of the pancreas, it will take a Whipple operation again to remove it.
Wow. Great question coming in from Janice, asking, how is a biopsy performed for pancreatic cancer? Thanks, Janice, for the question.
Yeah, Janice, great question as well. I think it, again, usually involves that endoscopic ultrasound. That's sort of our go-to method for trying to get tissue, fluid, any sort of sample from the pancreas. It's pretty safe. It's a same-day procedure, and it's actually done by our GI colleagues, and we do lots of them here at Hartford Hospital.
Mark asks, can you live without a pancreas?
Yeah, Mark, that's a great question, and I actually, to give further clarity on what I said before, there is another operation we do called a total pancreatectomy. We don't do those very often, but there are occasions where we have to remove the entire pancreas. So to give a little education on the pancreas has two main functions. There's what we call an endocrine function and an exocrine function. The endocrine function is controlling things like blood sugar, creating those hormones to control your blood sugar and preventing things like diabetes. The exocrine function is creating those enzymes that get made in the gland and then secreted into that pancreatic duct and passed out into the intestine to help digest food. Anytime we do a pancreatectomy, whether it's a Whipple or a distal, you have the risk of pancreatic insufficiency, meaning not having enough gland to perform those endocrine and exocrine functions. So one of the risks of a pancreas resection is developing diabetes if you don't have enough of the endocrine function, and developing exocrine insufficiency, meaning not making enough of those enzymes to digest the food. And if that happens, we have those enzymes in pill form that you take while you eat. Now, if you do a total pancreatectomy, we know that you're not going to make those enzymes, and we know you're going to become a diabetic. So in a situation where we have to do a total pancreatectomy, we work really hard before surgery and work closely with our endocrine colleagues to get you prepared for what life is going to be like as a diabetic. We often work with insulin pumps to try and control that, and a lot of work up front to understand, what the new quality of life is going to be and the changes that are going to be involved. But you can absolutely survive without a pancreas. It just, sometimes can change, your lifestyle if you develop diabetes or pancreatic insufficiency.
An anonymous viewer wrote in, I was told that once diagnosed with pancreatic cancer, a cure is rarely possible at that point. Is this true?
So that's another great question. And unfortunately, it really depends on the stage that it is found. If we find pancreatic cancer early, it hasn't spread anywhere, it's confined to the pancreas, and when we get it out, the final pathology shows the lymph nodes aren't involved, and we've really caught it early, you can absolutely be cured. Unfortunately, the percent of people that we find in that very, very early stage is low because of the issues we talked about before of early detection and it growing to a bigger size. If it's found at a much later stage, sometimes it can be very hard to cure. So it's really based on the stage.
And I think it's also important, just to sort of sum all of this up, is to really know your family history. And if your family history, if there is evidence of pancreatic cancer there, genetic testing may be an option.
Absolutely. If you fall into one of those genetic cohorts that put you at higher risk, absolutely give us a call. We'd love to see you and get you into our high-risk clinic. And also just listening to your body. Again, when something's not right, after a few days, don't ignore it and certainly seek medical advice.
Great advice. Speaking of advice, we appreciate you coming here in the studio. It's so great to see you here in person and not on Zoom calls, so it's nice to have you here with us. And really thank you and the team at Hartford Hospital, across Hartford Healthcare, with so much that you do for pancreatic cancer and the patients that are involved.
Thank you. I would just say, it really is a team approach. No one individual makes a difference in this sort of care. So I'm just very lucky to work with amazing doctors and team members, from the OR, from nursing staff to our support staff, to really make sure our patients do well.
It is when you speak about the team, and it really is a team that it stands behind just one patient. It's remarkable, from radiology to surgery to pre-op to post-op. It's remarkable the amount of people that it takes to treat just one patient.
Absolutely, but I think that's what makes the difference.
And that makes all the difference, is that multidisciplinary approach, that coordinated care of everybody coming together. So we thank you.
Thank you very much.
And of course, as always, we thank you for watching. We hope that you learned something from our very important discussion today. November is Pancreatic Cancer Awareness Month, but really to keep that awareness all year round is so important. For more information, just simply log on to hartfordhealthcare.org/cancer. I'm Hartford Healthcare's Tina Verona. Thank you so much for joining us today. We'll see you again real soon, but for now, as always, be well.